Assalamu alaikum. My name is Dr. Asad, and today we will be discussing epidemiology of blood disorders, particularly thalassemia. Yesterday, you must have gone through the session on anemia. Today, we will go through our learning objectives, and there are two learning objectives, but they are important. These are we will discuss epidemiology of thalassemia, and we will also learn about the control and preventive strategies for thalassemia. So, what is thalassemia? Thalassemia, as you can see on the word, it is a combination of two words. Thalas, and it's a Greek word. Thalas means sea, and mia means blood. So, sea plus blood. This name is derived from the fact that the, in the early history, Mediterranean Sea was the main area or was the main region from where majority of the thalassemic patients were diagnosed. And if you want to describe it in biological terms, so thalassemia is an autosomal recessive hereditary disorder. Recessive means that it needs to have the two defective genes in order to present itself as a phenotype, right? So if both the mother and the father, if they both contribute one defective gene to their offspring, so the offspring has two defective genes, then it will manifest itself as a beta thalassemia or thalassemia major. And in this disorder, the hemoglobin, the RBCs, the body is incapable because of the defective beta globin gene. It's unable to make either substantial amount of hemoglobin or it won't make any hemoglobin. There are the two types based on the uh, chains affected: alpha thalassemia and the beta thalassemia. Alpha thalassemia is of lesser severity as compared to the beta thalassemia, which can be fatal if not taken care of. So, what is the epidemiology of thalassemia? You people must have heard this word epidemiology. This epidemiology basically, word epi means on or upon, demos means people, and logos means study. So, in a nutshell, it's the study of the people. But the study of the people or the study of the disease in terms of its distribution, whether it, how it's distributed, for example, geographically, in the seasons and the determinants, like age, like sex, like a disease condition, or health related states or events in a specified population. I mean, it says one of the main presumption or assumption of epidemiology is that the disease does not occur in space. I mean, there must be some reason, there must be some logic behind it. So, a specified population can be a group of people, for example, specifically in women, like anemia, specifically in old age people, like Parkinson's disease, dementia, or like in children, rickets. So these are the various conditions, and the knowledge of this, or the knowledge to apply uh, these understandings for the control of these health problems. So, uh, risk factors for thalassemia, as we have studied or as we have discussed in the previous slide, that they are the determinants or risk factors. Like every disease, each disease has peculiar risk factors. These are the age. So, for thalassemia, it's the age of it's the disease of neonates or the younger age group, because it's the earliest uh, manifestation of anemia occurs in neonatal or in the 3 years period when the hemoglobin is depleted. Geography, Thalassemia belt. This is specifically the Mediterranean Sea, Cyprus, Italy, Greece, subcontinent. This is very common in this geographical area. Migration is a risk factor. For example, the people living in an area where thalassemia is very rampant or is very common, and when these people moved to the other areas of the other countries, and then they start having intermarriages, then the thalassemia also spreads there, and the thalassemia also spreads widely there. Family history, obviously, the person having the hereditary disorders, they are more at risk of having uh, thalassemia. Interfamily marriages or the consanguineal marriages within family marriages, they're also a risk factor for thalassemia. Other risk factors for not controlling or the poor control of thalassemia are the health care system of any country. So, beta thalassemia major in Pakistan. Since thalassemia is one of the most common blood disorder in the world, it is also a very commonest disorder of blood in Pakistan. We have the annual birth rate of 5,000 to 9,000 children per year, and then out of these, 5 to 7% are the carrier state. The carrier state means they have the gene, but they have not manifested the disease. The total numbers is said the total numbers are more than 100,000, but these are the numbers which are taken from the blood transfusion centers, from those children who came for the blood transfusion. But there are certain other uh, factors through which due to which the children cannot reach to these centers. So you can say that it's an underestimation. Registered cases are 10,000. This is a relatively old figure, so they must have been increased now. Mean life expectancy 10 years. This mean life expectancy has also increased because of the services provided by uh, the NGOs, the philanthropic associations, also because of the increased number of the blood transfusion centers and uh, and the other donors that supply medications to these anemic children. Beta thalassemia trait in Pakistan. So if we have a look at according to the ethnicity, we will see that uh, the overall, though the maximum trait that is being observed is in the Balochistan or the Balochi people. They have 8% carrier rate, and overall is 5.5%. So we know about that we do have the beta thalassemia or thalassemia in Pakistan, and it's present in almost all of the provinces, and we are having interfamilial marriages or cultures like that. So how can we prevent thalassemic births? Because that's the way that through which we can control thalassemia. So to control or to prevent thalassemic births, we have the tools in preventive medicine. We have primary, secondary, and tertiary preventions, right? And what what we what, let's see what we have here. We can prevent the births through the carrier screening. We can prevent the birth through genetic counseling as well as the prenatal diagnosis. So if we talk about the how can we find out thalassemia, these are the three strategies. We will discuss about these strategies in the coming slides. So let's say we are asked to find out thalassemia carriers in the population. One of the tasks given to the aspirants, let's say that he or she is asked to go and find out thalassemia carriers in the population. So how would you go about it? And why do you think it's an important thing? So it's an important thing because these are the carriers who gives rise to these are the carriers who give rise to the cases, right? And these are the ones which are easiest to identify when when we look in the scheme of the things, right? So and in primary prevention, we can identify the carriers by these strategies, by awareness and education. Awareness in terms of public awareness, yes, and the group awareness, like young mothers or the mothers of women of childbearing age, and awareness through pamphlets, awareness through newspapers, awareness through mosques, awareness through uh, school sessions, awareness through special programs, and education like education or educational institute. They can have sessions on thalassemia, risk prevention, and whatever risk and what not, and a policy of screening for detecting carriers. So, how can you go for detecting carriers? There is a specific things that we can go for detecting the carriers. First of all, you see, the word carrier gives us a very, it's a very vague word. I mean, if I ask you to go in search of carriers, you will have to limit yourself in order to make it manageable. So we start with the and the we start with the extended family carrier screening, because the nearest that we can approach and that can provide us the maximum yield is the nearest family members. So what is extended family carrier screening? Extended family carrier screening, it says that if a thalassemic patients are present in the family, then carrier screening before marriage to avoid marriage between two thalassemic carriers. So the easiest way out is to identify is to identify or to hold the thread and then trace it where it leads you, and then have screening of those family members. It can provide you the the maximum results. Then say you identify that okay, these are the carriers. Now, how would you explain the situation to the parents, grandparents, and other family members? Okay, you will provide them with genetic counseling. And what is genetic counseling? In genetic counseling, counseling is basically like the communication. It's the communication process to understand and adapt medical, familial, and psychological consequences of genetic diseases. Here, the healthcare provider or the psychologist, clinical psychologist, they sit with one or two basically the two family members, and they are uh, they have the expertise in counseling, and then they provide all the you can say bits and all the plus minuses of having a baby with beta thalassemia, right? And the, but they don't force the decision. The decision is that of parents, whether they would like to carry on with the pregnancy or they would like to abort. So, and the genetic counseling is again of two types: the prospective counseling and the retrospective counseling. Prospective counseling is the type of counseling in which takes place before the birth of the baby. Before the birth of the baby, during the antenatal visits, mostly during the antenatal visits, and the retrospective counseling is the type of counseling during which takes place after the birth of a thalassemic child have taken place, and during the retrospective counseling, the mothers are specifically more receptive to the advice given to them. So it works a little bit better than the prospective counseling. But again, here the damage has already occurred. So the focus is usually given on prospective counseling. Say the child has born. So how can we prevent further thalassemic births in a family? So first we tried to we identified the carriers. Then we said that okay, these are the carriers. We provide the genetic counseling. That these are the chances that your child will have thalassemia or that genetic disorders, and Now the child says the child is born. Now, how can you, as a public health professional, prevent further thalassemic births in this family? Here comes the role of secondary prevention of thalassemia, which says about the prenatal diagnosis. Here we go for the early diagnosis and the treatment. The prenatal diagnosis, or the prenatal means pre-birth. Prenatal diagnosis, in which the parents with the uh, affected children, they will be provided opportunity of medical termination of pregnancy in case of thalassemia major child, and in case of treatment. But again, the prenatal diagnosis takes into account the economic, medical, social, legal, cultural factors. Like cultural factors, in a sense that in our communities, it's said that in certain families they would like to have more children, and the more children to recessive couple, the more chances are there to have thalassemic baby. Treatment. So the last resort is the treatment. So the regular blood transfusion, but there are many NGOs, there are many blood banks which are sprouting or mushrooming in our country, in our cities, and they are providing blood transfusions. And because of these blood transfusions, the life expectancy of thalassemic patients is increasing. But again, these most of these blood transfusion centers, they are not properly regulated and don't have the screening facilities for infectious diseases. So it's adding more harm. They are adding harm as well. And iron chelation therapy, because of the regular blood transfusions, these kids, they tend to have iron accumulation in their body. This is known as the hemocytosis accumulation, and it accumulates in the liver, it accumulates in the other body parts, and they have ash gray appearance. Then that's very difficult. This iron chelation therapy this for removing this iron from the body, they have to have other medications. Desferrexamine. This desferrexamine is again has its own side effect and the costs associated with it. So the one of the better option which is present is nowadays is the bone marrow transplantation. But again, the bone marrow transplantation is a very expensive procedure and is difficult to have by most of the people in our country. And then the treatment of complications. Obviously, when we are having so much medications and things, uh, we're bound to have certain complications, and one has to look for those complications. Okay, then there is the secondary prevention. Secondary prevention, as we have said, that it is also about the prenatal diagnosis. So prenatal diagnosis, there are different methods of doing a prenatal diagnosis, and these methods include chorionic villus sampling to get fetal DNA at 8 to 10 weeks of LMP gestation, and PCR, the polymerase chain reaction, to copy and produce adequate DNA for analysis. It basically increases the PCR basically increases the quantity of the DNA, so it can be easily analyzed. And the or DNA analysis, genetic or DNA analysis to detect prevalent mutations of thalassemia gene. So these are the prenatal diagnosis. So first, what we have learned till now is that we can easily prevent thalassemia, and it starts with the primary prevention where there is no damage. Here we identify the carriers, and we uh, we strive to make them understand that not uh, it's not healthy we have two carriers marry each other, then if those carriers marry each other, then we go for the genetic counseling. And in this genetic counseling, uh, we discuss with them all the positives and negatives of having a thalassemic baby, but the decision lies with them. We don't force the decision. Then in secondary prevention, we go for the diagnosis. And also in the previous, we identify the carrier. In the prevention, we identify the carrier through carrier screening. And for that carrier screening, the easiest or the nearest one that we can pick up are the family members or the extended family members. Then in secondary prevention, we go for the diagnosis and treatment. The diagnosis includes the prenatal diagnosis and the treatment. Prenatal diagnosis is again of three types: chorionic villus biopsy, PCR, and genetic DNA analysis. And in case of the treatment, we have discussed the treatment was about the iron chelation therapy. Mainly, we give iron chelation therapy. And the treatment of choice is bone marrow BMT, or the bone marrow transplant. But bone marrow transplant is very expensive, and these treatments like chelation therapy, they have their own complications and expenses. So thalassemia control strategy. Thalassemia control goes with the prevention strategies. Now the control strategies, national programs in different countries that have controlled thalassemia, what they had in common was they have these four components: national programs for thalassemia control, they have the proper infrastructure, they have the patient treatment, and they have prevention of the disease. The prevention of the disease we have discussed in our earlier session. Now, let's have a look. Let's put our national lens on these components. The national programs, unfortunately, Pakistan has no national program for thalassemia control. We have different drafts prepared to be sent to the National Assembly by Sindh government, by by other provincial governments, but they have yet to be sent. They have not sent yet. So, and we have no proper policy. We have no proper policy for thalassemic patients, right? Um, and other countries, they have improved a lot by having they have improved their condition. In Pakistan, they were much worse than Pakistan. For example, Iran, Cyprus, Greece, Italy, their condition was much worse than Pakistan, but they implemented their policies, they improved their healthcare infrastructure, and nowadays in Iran and Greece, it's very difficult to find a single case of beta thalassemia. So it's controllable. So our national program has no policy yet. Infrastructure we have, in case of healthcare infrastructure, we have one of the finest infrastructure in terms of the basic health units and the rural health center, and but these are the buildings, like these are the structural infrastructure, but we don't have the equipments, we don't have the health staff. We have NGOs, we have philanthropists, we have people who have taken the initiative because one of their relatives died of thalassemia, so they took initiative themselves and they are working fine. But they are working in silos. All these people are working in silos. There is no there is no coordination between them. So each is working in his or her own silos. Then the patient treatment. Again, the patient treatment we have discussed about it, that it's that it's expensive. It has its own complications, and it's not feasible in the long run. Now, just giving you one of the example of legislature. of Thalassemia Prevention and Control. It was by Singh Assembly, and in 2013 they said that they have passed it. Okay, but its impact is is nowhere. I mean, the blood transfusion services, they're still not registering any patients with thalassemia. Neither they are tracking their extended family members. Neither they are not penalized. They are not being penalized for not registering those patients. So there's a lot to be wished for. So now, what about the tertiary care prevention? Tertiary prevention of thalassemia, the psychological support, obviously the person or the kid who is going through all these, what do you call, all these complications, all these miseries, and his or her parents, they do need a psychotherapist, and that, see, our we, we don't have any such services in our setup. So this should be given, this should be provided, but unfortunately it's not. Physiotherapy, those children, their chest, they become the barrel, they have the barrel shaped chest, they have respiratory problems, they have uh, problems in their skulls. So these need the physiotherapy, but again, we are like are uh, we are in we don't have that. Pain management, vocational rehabilitation. Vocational rehabilitation means they were involved in some sort of work, so they uh, so as to make them a useful member of the community, so that they learn a new skill. So when they go out to the community, if they are not studying, if they go out to the community, they had they uh, had a skill. They had a skill which through which they can earn uh, their livelihood. Pain management. And, pain management, of course, again for the pain management, uh, these patients has to take medications, painkillers, which sometimes produces they are ulceronogenic. They can produce ulcers, or in case of severe pain, they may have to take narcotic analgesics, and they may become dependent on it. So it's a not a good thing to look at. So in summary, what we have covered till now is that beta thalassemia is the most prevalent single gene hereditary disorders in worldwide, as well as in Pakistan and the neighboring countries. Its incidence can be decreased by targeting high risk groups. So, high risk groups means those groups which like having interfamilial marriages, as you know, this disorder, thalassemia disorder, is not randomly distributed in our society. There are specific target groups, and by focusing on those targeted groups, we can have very cost-effective strategies to control them. The preventative strategies that have controlled thalassemia in other countries like Cyprus, Greece, Italy, they have provide they have provided the evidence that it's controllable, it's preventable. So, with the hope and with the prayers that inshallah we will also eradicate, thalassemia will also be eradicated from Pakistan. Thank you so much.